patients have more options and
more.
The science is just evolving. So thank you for everything that you do.
I tell my patients every day, I can't change the fact that you have breast cancer. I wish I could, but I can change your experience with breast cancer.
Hello, and welcome back to 20-Minute Health Talk. I'm your host, Sandra Lindsay. On the first episode of our breast cancer series, we spoke with Dr. Susan K. Boolbol. It is our pleasure to welcome back Dr. Boolbol to the table as we continue our discussion on breast cancer awareness, early detection, treatment, surgical options, and recovery. Dr. Boolbol, it's so great to have you back with us. So let's get back to the core surgical options. Can you break down the fundamental differences between a lumpectomy and a mastectomy? And what are the key factors that helps you to decide which is more appropriate for a patient?
So a lumpectomy is the same thing as a partial mastectomy. It's removing part of the breast, not the whole breast, just part of the breast. Patients typically like to hear the word lumpectomy better than partial mastectomy, which I can understand. And that is called breast conservation also, because we're conserving the breast. So we remove the part of the breast that contains the cancer and leave the rest of the breast in place. That's a lumpectomy. A mastectomy is where we are removing the breast tissue and then either doing reconstruction with the help of our plastic surgery colleagues or doing what we call a flat closure, not doing reconstruction and just closing the skin so that the chest wall or where the breast was is now flat. When do we decide to do a lumpectomy versus a mastectomy? And that's where patient preference can come into play. So if I can safely remove the area of the breast that contains the cancer and have the breast at the end of the surgery looking like the breast, then a lumpectomy is possible. So a lot of it depends on the size of the cancer compared to the size of the breast. So there's no specific size that you say, oh, I cannot do a lumpectomy now, because it all depends on the size of the breast that we have to work with. And that makes a big difference. But regardless of what we do, it is important to know that a lumpectomy and radiation overall has the same survival as a mastectomy. Now, there's always exceptions, and there's certain types of breast cancers that we still need to do a mastectomy on, such as something called inflammatory breast cancer. But overall, for the majority of breast cancers, doing a lumpectomy and radiation is the same overall survival and outcome as doing a mastectomy. And that's another myth out there. Women come in and think, I want to live, I need to live, I have a lot of living left, I want a mastectomy. And we have to slow down, back up, and explain that overall survival with a lumpectomy and radiation is equivalent.
So that's interesting and great to know. So thanks again for clarifying that. I'm learning so much.
There's a lot of myths here.
A lot of myths. And what about a double versus a single mastectomy if only one breast is involved?
So we know that in the majority of women, removing a healthy breast will not affect their overall survival. That survival is determined by their initial breast cancer, not removing the healthy breast. It will not alter outcome. So, are there cases that it will? And if a woman has a genetic mutation, if they're young, in their 20s, 30s, 40s, and they have a genetic mutation, which means that they were born with something in their DNA or genes that predispose them to developing breast cancer. That also means that they're at higher risk for developing another breast cancer in the other breast. So in those women, doing what we call a prophylactic mastectomy, meaning removing the breast that does not have breast cancer, can alter their outcome. But that's the minority of women.
How about women who test positive for the BRCA gene?
That's exactly what I was just talking about, the genetic mutation. So the most common genetic mutations that people have heard of are exactly what you said, BRCA1 and BRCA2 mutations. But there are several other genetic mutations out there. But that is a common reason why women do a bilateral mastectomy, is that they have a genetic mutation.
Are there other more exciting advancements you're seeing in surgical techniques, particularly in terms of minimizing invasiveness or just improving cosmetic outcomes, such as reconstruction?
So improving cosmetic outcomes has come so far. And I really prefer to call it an aesthetic outcome, because when we think of the word cosmetic, we think, oh, cosmetic surgery, oh, it's vanity. Replacing a body part is not cosmetic. It's aesthetic. It's reconstructive surgery. And that may seem like semantics, but I really don't believe that it is. We're replacing a body part that has been removed. So we would never refer to replacing any other body part as cosmetic.
That's
so
fair.
Why do we do it with the breast? And it's done all the time. It's referred to in that way.
Well, thanks for that clarification.
So because it really is. It really is. There are some cultures that won't do breast reconstruction after a mastectomy because they think of it as vanity. And if they're approaching it as vanity, then it's almost that the cancer will come back because they were being vain. And I have to explain, this is not cosmetic, this is reconstructive surgery. But we've really moved quite far into this with even lumpectomies, where we do what we call oncoplastic surgery. So, back in the 90s when lumpectomies were really started being done, in the late 80s and 90s, large amounts of breast tissue were taken out, and the skin was just closed over it. And then the breast was radiated, and to be honest, the breast did not have a very good aesthetic outcome. But it was the best that the surgeons could do. It was all they knew. So now, fast forward decades, we do oncoplastic surgery, where what we can do is we remove that abnormality, we remove that area of cancer, and we can remove the remaining breast tissue around to maintain the shape and the contour of the breast. One of the best parts of my day is when women come in after breast surgery and they've had their mammogram and they say, the technician couldn't find the scar. They had to ask me where it was. I mean, that is just a great feeling for the patient and, of course, me as the surgeon.
Yeah.
But that's the goal. And that really makes such a difference, because if these women look in the mirror every day after getting out of the shower and they see, a breast that looks somewhat deformed, what it does is it forces them to think about breast cancer every day. Well, 3 years out, 4 years out, 10 years out, the last thing I want you thinking about every day is breast cancer, because you're doing great. So if your breast looks like your other breasts, you're not thinking about breast cancer every day. That doesn't mean you never think about it, but you're certainly not thinking about it every day because it's not right there in front of you.
That's amazing. How about nipple sparing versus skin sparing mastectomies, immediate versus delayed reconstruction?
So you've done your homework. Look at all this.
I have.
Look at all this.
You're the best. I want to learn as much from you for our listeners.
Yeah, no, I love this. So interesting. When I trained, 100 years ago, back in the 90s, every mastectomy we did, we removed an enormous amount of skin, and we removed the nipple areolar complex with every woman, and some would have reconstruction and most would not. And fast forward to today, where most of the mastectomies that we do are what we call nipple-sparing mastectomies. We make an incision underneath the breast, remove the breast tissue from there, leave the skin, leave the nipple, and the reconstruction is done from underneath the breast. And when a woman looks at the breast, it looks great. It matches their native breast. And again, the aesthetic outcome matters. Now, there's no sensation in that nipple, but now we're into nerve-sparing, not only nipple-sparing mastectomies, but nerve-sparing mastectomies, where the goal is to preserve the sensation. It's not 100%, it's not perfect, but the only way to get closer to where every woman can have that is by doing it, and that's what we're doing. So we've come so far in the surgical world and the treatment of breast cancer.
That's amazing and encouraging to hear that our patients have more options. And
more.
The science is just evolving. So thank you for everything that you do. And you're just so passionate about.
I am. I can't even help myself with it. It's, and it's about making a difference in people's lives. And as I tell my patients every day, I can't change the fact that you have breast cancer. I wish I could, but I can change your experience with breast cancer. And as an individual breast surgical oncologist, and as leader of a team, and I'm very involved nationally and internationally, that's the goal, is to change the experience and change the outcome.
That's amazing. So let's pivot now into the recovery phase and talk about what should patients expect during that phase and what kind of support systems are crucial for healing, both physically and emotionally.
So the physical part is easier than the emotional part, as in so many things that we go through in life. Breast cancer is bigger than any one person alone, and it is time to rely on your community. As women, we are used to taking care of everyone and everything. We take care of our families, we take care of our spouses, we take care of our children, we take care of our parents, we take care of our people at work. Now, if you are diagnosed with breast cancer, it's time to take care of you.
But there's still so much shame and privacy around it.
And that is something we need to change. This is a very common disease. The statistics don't change. It's 1 in 8 women. Rally around. I mean, who's better at taking care of women than women? Let's rally around and get everyone involved. I say all the time, as if a family member or a friend is diagnosed with breast cancer, what happens? You call and you say, let me know if I can do anything. Mm-hmm. Don't say that. Say, I'm setting up a meal train.
Yes.
What are your favorite foods?
Or I'm coming to treatment with you.
I'm dropping off dinner for your family tonight. It will be at the door. I don't even need to say hello. I'm there if you want to, but it will be at your door. Your kids, you're getting treatment on Tuesday. I have play dates arranged for your kids every day for the next 2 weeks. We can all think of something to help. Just be that person to organize it, as opposed to waiting for someone to ask. We're not so good with asking for help. We're just not. So be there, be that person to just lend the help. Here it is. Here's what I've organized for you. I know you have an 8 a.m. appointment. I'm driving you.
Yeah.
Be there. Don't wait to be asked. Just be there.
So what other physical, things can we expect in the recovery period? How long after surgery will a woman be out of work? Because that's usually a big concern. Can I take care of my kids? Can I, lift my arm up? Can I have, quiet time with my husband? What are some recommendations?
So everything you mentioned was about others.
Yeah.
Can I pick up my kids? Can I take care of my kids?
Okay.
Can I go to work? But that's normal. That's human nature, especially for women. Can I still take care of everyone else? And I say, this is your time. We don't get a lot of time where it's about us in life. This is your time. So thankfully, the recovery from surgery is straightforward. The physical recovery. And most women these days have lumpectomies. The majority of women have lumpectomies. And the recovery is pretty straightforward. We frequently will remove some lymph nodes underneath the arm. Thankfully, breast surgery is not a very painful recovery. But remember, pain is subjective. Everyone feels pain differently. We're really good at controlling pain without the use of narcotics these days. So, and that's an important factor, is we don't want to use narcotics for breast surgery. So there are many things that we do in the operating room now to reduce post-operative pain, which is pain after surgery. And we're at the point where women frequently just take Tylenol or, ibuprofen. It's very common. Well, I tend not to use narcotics at all because we do so many things in the operating room to reduce the pain.
So I know you've been given a lot of advice throughout our conversation, but if you had to give one piece of advice, and I know that's difficult because there are so many things, information to impart, but one piece of advice that you'd give to a patient who is newly diagnosed and feeling overwhelmed by the thought of surgery.
Be kind to yourself. Allow yourself to feel these feelings. Having cancer is similar to a grieving process, but do not get paralyzed by fear. Knowledge is power. I always say, one of the most important questions to ask your new team of physicians that you never wanted, but now that you have, is, what are my options? When they say, here's what you should do, your response is, what are my other options? So that you have a full breadth of knowledge with which to make your decision.
And we like to end on a hopeful note here. So what's your message of hope to someone who is a survivor, someone newly diagnosed, someone who just wants to know for the future, a husband, a child, a family member, a friend who is listening?
I have to say, with breast cancer, it is all hope. It is all hope. And that is honestly what allows me to continue to do my job day in and day out. Because, as I say to patients, especially with early diagnosis, they're going to be here for a long time. I hope you're saving for retirement because you're going to be here for a long time. It's not breast cancer that you're going to statistically die from. We will all die. But women with breast cancer have nothing but hope out there. But early diagnosis is key. So get your mammograms every year from 40 and above. Please, if you've had your mammogram, then talk to your loved ones. Make sure they've had their mammograms. It is critically important. And I thank you for doing this because this helps get the message out.
Thank you so much for joining us today on 20 Minute Health Talk. It's such a pleasure meeting you in person, chatting with you, and just learning from you, and to be able to bring this to our 20 Minute Health Talk listeners. Thank you so much.
Thank you. This has been wonderful.